Today on Primary Care, heart disease, the only disease where its first warning could kill you.
See, what you gotta realize in cardiology, someone dies almost every night. And you lay there and you actually can hear it.
Hello, I'm Dr. Lonnie Joe, and welcome to Primary Care. African Americans with heart disease are more likely to be taken care of by their primary care physician. But the data suggests that the best care for treating this disease happens in the cardiologist's office. Joining me today to talk about the treatment and care of African American patients with cardiovascular disease is the president of the Detroit Medical Center Heart Hospital and the Cardiovascular Institute, Dr. Theodore Schreiber. Dr. Schreiber, thank you for joining us.
Good afternoon, and I'm delighted to be here today.
First of all, Dr. Schreiber, let me congratulate you and all of your fine and hardworking staff that has put this magnificent Cardiovascular Institute together. We know it's been a long haul and a lot of hard work, and now it's finally up and operating. You should certainly be congratulated.
I appreciate your warm thoughts. We think that this institution was built in just the right place to help the greatest number of people given the high prevalence of cardiovascular disease in the Detroit community.
Let's get right into this, Dad. Why in a practice like mine are we seeing alarming rates of cardiovascular disease in the African American population?
African Americans have a higher proportion of high blood pressure, higher proportion of patients who are overweight, a higher proportion of patients who are diabetic, and a higher proportion of patients that have kidney disease, which is a risk factor that accelerates the formation of blockages.
So when we talk about all of these things, we're really looking at what primary care does and how it leads to the heart disease that people develop and why people eventually should be referred who have heart disease to a cardiologist.
That's absolutely correct. I think that the most effective way of treating a serious disease such as heart disease is to prevent it altogether, and that's why the role of the primary care physician is very, very important. Unfortunately, frequently the heart disease has been found by the primary care physician to be well along advanced, and at that point to get the best treatment and the most rapid treatment, referral to a cardiologist is very worthwhile.
Now, Dr. Schreiber, you're a surgeon, a cardiologist, interventional cardiologist. Help our audience understand what those terms mean.
So if a cardiologist, a specialist in heart and vascular disease, goes and gets additional training for interventional cardiology, he and she will be able to treat the manifestations of heart disease with minimally invasive techniques, catheters, using the blood vessels of the body as a port of access to deliver equipment, minimally invasive equipment, to treat problems in the heart and vascular system. So for example, the most extreme example of this would be to replace a valve, an aortic valve, by delivering it on a stent and delivering that through the artery in the groin. So that's typically an example of what an interventional cardiologist do. So as a result, we tend to spend a lot of our time in laboratories that use X-ray equipment to delineate the blood vessels. And it's a very, very high-tech operation that you need special training for, typically 1 to 2 years of additional training beyond being a clinical cardiologist.
Talk to us a little bit about stroke, the companion disease or the companion sequelae a lot of times of cardiovascular, the vascular portion of disease that, again, we see an alarming amount of.
So we have a particularly high risk of stroke amongst African Americans. The risk factors for stroke are the same as the risk factors for heart disease: high blood pressure, diabetes, being overweight, having a high cholesterol. In addition, the heart disease itself, people with weak hearts can develop clots that develop within the heart, and particularly if there are certain bad rhythms such as atrial fibrillation, these clots can then go from the heart to the brain and give so-called embolic stroke. So heart disease and stroke are intimately connected, and the prevention of heart disease is an effective way to also prevent stroke.
Also, we see a wide spectrum of patients, but one thing that we've been keying on recently in primary care area of medicine is the overweight, slightly overweight, perimenopausal, postmenopausal female who've lost the hormonal protection and who has a history of high blood pressure and or diabetes. There seems to be a tremendous uptick in terms of us seeing heart disease in that patient group because it doesn't present the same way. These people sort of fool us in their presentation, and if we don't take the extra step or go the extra mile in the workup of those patients, we tend to miss to some degree the severity of the cardiovascular disease. What has your experience been in that particular subset of the population?
So the presenting signs of heart disease, in particularly middle-aged ladies, is different than that in men. All the studies and hence the textbooks that have been published list the presenting signs, for example, of insufficient blood flow to the heart as being chest pain in the middle of the breastbone going down the left arm. Well, most of those studies were done in men. Had we started doing most of the studies preferentially in women, we'd find that the chest pain is not as frequent, that perhaps there may be nausea, there may be shortness of breath, there may be sweats, the pain may occur in the shoulders or in the bones of the back. So clearly, as internists and as cardiologists, we need to have special attention to middle-aged ladies who do have a high prevalence of heart disease, as you described, and we need to listen not only just for the textbook sorts of symptoms, but other symptoms that may be a little bit different or altogether different, and then give the appropriate diagnostic test and treatment.
So basically, making sure that patients in all categories get what they need in terms of attention to heart disease, especially in the high-risk groups.
Absolutely, and that's why in an individual that the primary care physician detects as being at very high risk for heart disease or perhaps having some symptoms, maybe not classic, referral to a cardiologist may be worthwhile to get an additional, more detailed and more complete evaluation.
I'm getting ancient now, Ted, but we were taught that the most common symptom of a heart attack in Ann Arbor was no symptom at all. It was sudden death being the most common symptom, and that's the frightening thing. The patient that doesn't necessarily have symptoms, or the symptoms are vague and the symptoms are not being put or placed higher up the list in terms of it being suspected heart disease in this category.
So, Lonnie, I think you're absolutely correct. If we were to look at the prevention of heart disease and serious endpoint events as death, probably the most worthwhile investment of resources would be to find those individuals that are at very high risk of having sudden cardiac death who may not have any symptoms. Those would be individuals that have very weak hearts, particularly hypertensives, individuals who are diabetics, and individuals that are at risk for heart disease who have not the usual symptoms, maybe a little bit of sweating, particularly fatigue, and so on. These individuals should probably undergo appropriate evaluation, which would include more than just an electrocardiogram and certain blood tests, would probably include an ultrasound imaging of the heart to see if the heart is weak. If the heart was found to be weak, appropriate treatments and further tests would be done that can dramatically decrease the risk of heart attack and sudden cardiac death in this high-risk population that I've described.
Very interesting. We're going to go to a break. Up next, a Detroit Medical Center heart patient comes to grips with the reality of having had a heart attack.
Since 1918, the Detroit Medical Society has been there for physicians, patients, and the community. We were there then, and we're here now. The Detroit Medical Society, here for you.
Hart, what's going on?
I'm leaving.
Why? What did I do?
Not enough. You constantly ignore me. You barely eat anything healthy. You're half as active as you used to be. The pressure is just too much. I quit.
Okay, I get it. I'll do better. Just please
Don't leave. Okay. But remember, if I go, you go.
Listen to your heart. Don't let it quit on you. Uncontrolled high blood pressure could lead to stroke, heart attack, or death. Get yours to a healthy range before it's too late.
Welcome back to Primary Care. Even though both his father and grandfather died from heart disease, Richard Welch was unaware that he had the same condition until his heart began to fail.
My name is Richard Welch. I'm in the retail fur business, and actually I had my heart attack at age 63. I was totally unaware of it, and I've been an athlete all my life. I played sports, I do everything, and I've never known of any I boxed, any heart condition. And so when I did find out about it, I was somewhat surprised. What happened is I did a fashion show that actually was a commercial that night. And I didn't want to take any security, so I said, well, I handle myself. Well, these bags with furs on them can get pretty heavy. And I was, I did the show, left the show and came back here. Luckily, a friend of mine was a part of the show, a guy named Fast Freddie. I said, Freddie, help me out a little bit. He helped me out, put him in the truck. I drove back here. And when I got here, I had the furs on a roller. I rolled them in and just sat out right here. And I sat there for about an hour. I was just so tired. Got them put in. Then I went home, and when I came into the house, she looked at me and said, what's wrong with you? I said, nothing. I said, I'm tired. I'm going to lay down. And so naturally, her being a nurse, she took out a stethoscope. She said, oh, no, we're going to Harper. Went to the hospital. And when I walked in, I mean, they started panicking. I mean, I didn't realize I was that sick. I mean, putting nitroglycerin under your tongue, shooting things in your arms. And I tell anyone, don't wear anything to the hospital that you want to bring home, because they tear it off you. And then my wife kind of explained it to me, just what was happening. And they let me know then that it's you're not going home. You're going to be here for a while. One valve was 95% blocked, and the other one was like 85% blocked. So they kept experimenting with different things, and then the doctor came in and said, we're going to do some other surgery. I had the stents put in, then I had a defibrillator and the pacemaker, which is the new thing. It's the Rolls Royce. It's both of them together. But I was there for 3 weeks the first time, and I'm so happy to come home. See, what you got to realize, in cardiology, someone dies almost every night, and you lay there and you actually can hear it. I didn't know how bad I was, actually, until after it was all over. And I had to go do a commercial for the doctor, which I thought was a commercial for the public, but it wasn't. It was a commercial for other doctors in cardiology. And what they talked about is my condition from where I came from to where he brought me. And I listened to him, because he said, he had never told me this. When he first met me, he was not so sure he could save me. I said, what are you talking about? You didn't tell me that. He said, but I told your wife, she knew, and she never said anything. He said, plus there was no need to tell you. Why? It was something I found that was hereditary in my family, and to my doctor I found there was nothing I could have done to really avoid it. Then I started thinking back at many of us, my grandfather, my father, my uncle, the ones who had passed, and that they had the same heart condition. This is what I can share with you now that I've survived a heart attack. I can share that I was fortunate. I had a wife that was an RN. I had a primary care doctor that sent me to the proper people in terms of cardiology. I had a doctor, the cardiology doctor, that took an interest. I listened to what he said. I found that there's only so much you can do in terms of myself. I thought I could work 80 hours a week. Well, as you get older, you can't. You have to eat everything in moderation. Believe me, a lot of things that'll hurt you only hurt you if you overdo it. And that's all. But your main thing, you've got to listen to your doctor and be aware of your body. If you do that, your chances of surviving a heart attack are a lot better.
Take a deep breath. When I met Richard, he was presented with an advanced stages of his disease process, and he was determined to be too high risk for conventional bypass surgery. Here we have this advanced technology. We're actually the largest with the largest experience in the world using what we call a left ventricular assist device, which is a device that we put in the leg that gives us the ability to do high-risk intervention safely. We did that with Mr. Welsh, and he had a fantastic outcome. As you can see, he avoided surgery. He's able to walk and enjoy his life, and his quality of life has been improved significantly. His heart function was extremely weak when we met him because he had severely blocked arteries. With the opening of his arteries and the medication and the rehabilitation, he's had significant recovery, and it's manifest by increasing his quality of life and his mortality and longevity. He's expected to live a normal life now.
Thank you, Jesus.
Dr. Schreiber, Mr. Welch's cardiologist, Dr. Kaki, told him that he had one vessel that was 95% involved and a second vessel that was 85% involved. How serious was this for this particular patient?
This is very serious. This level of severe blockages leads to insufficiency of blood flow even at rest and predisposes the patient to weakening of the heart and possible cardiac arrest.
So his family history, father having heart disease and having died from it, grandfather having heart disease and died from it, probably was a tip-off for his primary care physician in some way that there may be the development of underlying cardiovascular disease in this patient.
Absolutely. There are studies that show that if you have a first-degree relative, brother, sister, or parent with serious heart disease at a relatively early age, you too are at risk for having that and should undergo evaluation.
Mr. Welch, former athlete, walking every day, probably used to exercising to some degree, but still turns out to be at high risk for an event to occur.
No question about it. The physical activity, being an athlete, being very active, probably permitted him to have the event at a later age than otherwise, but he has too many risk factors and probably very, very advanced disease before detection and treatment occurred.
So basically, here is a patient that probably represents, hopefully not, but thousands of people that this Cardiovascular Institute is going to service.
This is one of the focus for our institution. We also want to be very, very active in prevention, as I've mentioned earlier. How can we find these patients at a very, very early age, and how can we educate them to get their so-called modifiable risk factors, the blood pressure, the cholesterol, if they're smoking, to stop smoking, if they're overweight, to lose some of that weight, if they're on a bad diet, to improve the diet. That's really our focus.
Dr. Schreiber, what's being done to address the increase or the type of congestive heart failure that we see in the African American community? Seems to be different. My African American patients get their heart failure from uncontrolled or improperly treated hypertension, whereas non-African American patients seems to get their heart failure to a greater percentage from coronary artery disease. What is happening in terms of the treatment and early detection in both of those? I know you touched on it early, but in this particular instance of heart failure, I think it needs to be focused. It's the #1 discharge in the Medicare system in this country from a hospital. So how is this different in terms of our focus as treating physicians?
The assessment of high blood pressure can begin very early on. It can begin in the community even before you see a physician, by screening, by measuring your own blood pressure, particularly if you have a family history. The treatment of high blood pressure is an enormously powerful technique to prevent weakening of the heart, and in fact to prevent the crosswalk to arteriosclerotic, to blockage disease, which is more common in the Caucasian population in our state. The point is that for both populations, early detection is key. Look for high blood pressure, look for a family history, look for what does the electrocardiogram look like, get an ultrasound of the heart done early on if there's a risk factor for having heart failure, for having a weak heart, because getting to patients early gets them at the point where you can prevent the deterioration of heart muscle dysfunction. So it's a very effective way of preventing death, debility, and hospitalizations.
So we're back to the basics. Early detection can lead to prevention.
Numerous studies have actually demonstrated that, Lonnie. The difficulties that we have, particularly in our community and in communities where there's not sufficient access to primary care and cardiovascular care, is that the detection just isn't getting done. So my mission as president of the Heart Hospital, probably more important than any other single thing that I do, more important than putting valves in people through catheters and so on, is actually developing a good access program for our population, an outreach program where we can educate the population of Detroit and the surrounding communities on looking for risk factors, treating these risk factors, and then coming to organizations such as ours. And we have many fine organizations in Southeast Michigan for the treatment of cardiovascular disease, but the point is outreach, education, and access.
Ted, when we come back, we're going to ask you a little bit about inflammation in the vessels and inflammation testing. Stay with us. We're going to go to a break, and we'll return right after this.
This is where heart doctors throughout the Midwest are bringing their toughest cases, where specialists from around the world come to learn, where patients who couldn't be saved before are being saved. The all-new state-of-the-heart DMC Heart Hospital. This is Detroit, rising, medicine advancing, the future unfolding. The new DMC Heart Hospital. This changes everything.
Welcome back. We're here in the beautiful setting of the Detroit Medical Center Heart Hospital and talking with its president of the Cardiovascular Institute, Dr. Ted Schreiber. Let me ask you a little something about Star Wars aspect of this. You know, the new kid on the block right now is inflammation testing and how we can determine or assess the inflammation in the intimal lining of the coronary vessel. And there are blood tests out here now that seem to pop up every 2 months or so in terms of getting physicians' attention as to where you are in actually determining the instability of the coronary vessel itself. Now I say that because, as you know and have taught us, that a lot of patients have adequate or normal heart caths, meaning that the lumen of the vessel is not compromised, and we punt to medical management, but there still could be a great degree of instability there that is not addressed just by angiography. Would you comment on that kind of testing for us?
Sure. So a lot of folks think they're not overweight, they're not hypertensive, they don't have a family history, you don't smoke, you're home free. And yet some or more of these folks get heart attacks. Why? Turns out that even if you have a little bit of deposition of plaque inside the blood vessel, that plaque can be made so-called unstable, a vulnerable plaque, by various agents of inflammation inside the blood vessel. This inflammation may be triggered, for example, by infections such as the influenza. It's well known that during bad influenza seasons, the heart attack incidence double, and in fact, flu vaccines are very effective way for an individual in my age group, 60, to prevent heart attacks. So viral infections can trigger inflammation. It turns out that high levels of fat in the bloodstream, for example, if you have a nice juicy double cheeseburger, that will trigger acute inflammation within minutes. And this inflammation can cause a little bit of plaque to actually rupture, like a blister inside the blood vessel. And once a plaque ruptures, it very rapidly accumulates clot that then shuts off the blood vessel. So inflammation has been found to be a very important trigger of so-called unstable coronary disease, whether heart attacks or unstable angina. And if we know how to detect inflammation and then how to treat it, it makes sense that we can actually decrease the incidence of heart attacks. And in fact, it turns out that so-called statin drugs, the torvastatin, simvastatin, a number of generics are available, and also brand name products. Some or more of these agents are very effective at cutting down inflammation. In terms of commonly available tests to look for inflammation inside the vascular systems, a so-called high sensitivity C-reactive protein test, HSCRP, can be ordered by the physician to see if it's very elevated. And there have been now a number of studies showing that if you have a high level of HSCRP, if you take statin drugs, you can lower your risk of having a heart attack and even a stroke. There are some Star Wars type of techniques now where we can actually put catheters inside blood vessels that employs something called Raman spectroscopy. There's a big word that I'm trying to pronounce correctly, but that can tell us which plaque is actually inflamed. And I think some of us have seen reports also from institutions such as the Scripps that there is now an antibody that inflamed plaques generate that you could actually predict a few days before a heart attack if it's going to occur. Now that's highly, highly experimental and has only been shown in one study to have effects in maybe a study population of 10, but there's a lot of research going on, some of it here, that hopefully in 5 to 10 years will help us get a handle on inflammation.
Very interesting. Star Wars in the making.
Absolutely.
Good. Well, it is good to hear that we here at the Cardiovascular Institute are in the forefront and the leading edge in terms of prevention, detection, and treatment. Again, thank you, Dr. Schreiber. It has certainly been an honor.
My honor, and I'm delighted.
Thank you. Thank you.
Thank you.
From the Detroit Medical Center Heart Hospital, I'm Dr. Lonnie Joe. See you next time on Primary Care.
Primary Care was produced with the participation of the Detroit Medical Society, representing physicians, patients, and the community.